Okay, let's take a look at this case now. We're going to look at atrial fibrillation. Here is the case. A 58-year-old woman comes to the physician's office complaining of feeling lightheaded for the past week. She says she can feel her heart racing in her chest. She mentions she has been staying up late for the past few weeks because of her workload. Medical history reveals well-controlled diabetes mellitus. Physical examination reveals an anxious woman with pallor and mild diaphoresis. Cardiac examination reveals an irregular beat, and the vital signs are as follows. So her temperature is 36.1, respiratory rate is 22, heart rate is 142, and blood pressure is 118/55, and the glucose is 130. So this picture is different. It's something I just copied from Google, so ignore that. So think about these vital signs first. So next we have to think about the what clinical and electrocardiographic abnormalities that are commonly associated with this condition. So we have lightheadedness, palpitations, anxiety, pallor, diaphoresis. These are commonly associated with atrial fibrillation. Likewise, as in this patient, heart rate is elevated and borderline hypertension is possible. The electrocardiogram shows an absence of P waves, irregular RR intervals, and tachycardia, as in this patient. So irregular, uncoordinated atrial contractions can lead to tachycardia and stasis of blood in the left atrium. The development of a clot within the heart often ensues. So next we have to think about the appropriate treatment for this condition. So continuing on, let's think about the appropriate treatment for this condition. So I've written those at the top. Basically, the patient's heart rate needs to be slowed. To this end, beta blockers, calcium channel blockers, or digoxin are indicated. Metoprolol is a beta blocker that slows conduction through the atrioventricular node, the AV node, thereby slowing heart rate. Cardioversion to a normal sinus rhythm may also be considered. However, care must be taken not to promote thromboembolism, which can occur if cardioversion is performed more than 48 hours after the onset of atrial fibrillation due to stasis of blood within the atrium. A transesophageal echocardiogram can screen for a left atrial thrombus, or the patient may be given an anticoagulant like warfarin for several weeks before cardioversion is attempted. Okay, and next we're going to think about how do heparin and warfarin work together to treat this condition. Given intravenously, heparin activates antithrombin 3. Its effectiveness is determined by partial thromboplastin time, PTT, which reflects activity of the intrinsic pathway. Given orally, warfarin impairs the synthesis of vitamin K-dependent clotting factors 2, 7, 9, and 10. It is monitored by prothrombin time, PT, which is the extrinsic pathway. And continuing on, why does paradoxical coagulation sometimes occur after warfarin therapy? Warfarin also inhibits the synthesis of protein C and protein S, because proteins C and S inhibit factors 5A and 8A. A deficiency in these proteins promotes coagulation. So there we have it. Atrial fibrillation, read from this book, First Aid Cases for the USMLE. So there you have it. Thank you for listening.